Thank you very much. It's a privilege to be here. What Dean Bibb didn't mention is that she and I worked at the Uniformed Services University of the Health Sciences for quite some time, and it's a privilege to be here at Wichita State University. I've actually known your provost, Tony Vizzini, ever since we were in 9th grade. We did high school and kind of supported each other through 4 years of high school and the rest of life. And Tony, I must tell you, I think there's this guy named Michael Vizzini who I used to sit down and have conversations with, who'd be smiling on both of us today. That's Tony's father. I'd like to talk to you today a little bit about cancer control. How do you decrease death and suffering from cancer and what's going on? First, I'll start out, as we always do, with what our conflicts of interest are. I work for the American Cancer Society. I'm a professor at Emory University in the School of Medicine and the School of Public Health. I have a gig at CNN. They keep me around to make Sanjay Gupta looking good. They put us on TV every now and then, and the contrast between the two makes him look even prettier. I work for the National Institutes of Health, CDC, and the Department of Defense for a number of things, and I don't work for any drug or device manufacturers. About 4 years ago, I had this book, which was on the New York Times bestsellers list for a while. I'm not here to promote the book today, but Dr. Vizzini is in the last chapter. I'm going to talk to you about cancer control. What is cancer? Where have we come from? Where are we going? And where are we right now? Quite honestly, 1.6 million Americans will be diagnosed with the disease this year. About 600,000 are going to die from the disease this year. I'm a medical oncologist and epidemiologist, so forgive me for showing you graphs with numbers. In 1900, I'm frequently asked, how are we doing in the war on cancer? And we should talk about that war analogy sometime. But how are we doing in the war on cancer? And the answer is, in 1900, for every 100,000 Americans, 64 died from cancer. In 1991, for every 100,000 Americans, 215 died from cancer. And now we've had this 25% decline in the last 24 years to 163 per 100,000. So starting in the early 1990s, we started doing better. And that 25% decline actually means that 2.1 million Americans did not die from cancer as a result of cancer control efforts, primarily smoking, but other things as well, and we'll talk about some of those things. But can we do better? Well, the first answer to that question is to just manipulate the numbers a little bit. You see, college-educated Americans have a death rate that's 25% lower than non-college-educated Americans, or more than 25% actually. And that means that if every American in the United States had the risk of death from cancer of college-educated Americans, instead of 600,000 deaths this year, there would be 450,000 deaths. So it means that we can do something to save at least a quarter of the people who are dying from cancer, or prevent at least a quarter of the cancer deaths from happening. Now let's lapse into a brief history of cancer. I'm about to show you an Egyptian document, a papyrus that was found in the 1860s. It dates back to 1600 years before the Christian era. It's an Egyptian hieroglyphic, and it actually is the first known description of cancer. And it talks about cancer, and it says, do nothing, for you can't cure it. But this is the first written description of cancers discovered in the 1860s. It goes back to 1600 BC. Cancer was a rare disease for most of history, well into the 18th and 19th century. It was a rare disease. The first modern discussions of cancer and cancer prevention were by the British surgeon Percival Pott, who noted that young boys who were employed to do chimney sweeping duty frequently developed scrotal cancers, what we now call squamous cell cancers of the scrotum. And he was actually the person who theorized that it was actually chemicals in the soot in the chimney that actually caused these scrotal cancers. Now, what is cancer? Cancer is actually uncontrolled cell growth. We all learned in high school that one cell becomes two, two cells become four, four become eight, so forth. Now, the German pathologist Virchow, Rudolf Virchow, in the mid-1850s did a series of autopsies with his medical students at the University of Berlin. And they actually are the people who defined what cancer is using the biopsy. They literally did autopsies on women whose breast had actually had the cancer erode through the skin, such that there's a big, large sore there, but the women ultimately died from infection and other things, and they figured out that the cancer had spread to the liver or to the lung or to bone or brain. And they were the people who worked out the technology of cutting the tissue very thinly, putting it on a slide, and staining it. First, they used carmine stain in the 1850s. Later on, about 30 years later, Dr. Virchow, his friend, Dr. Bayer of the aspirin, taught him about H&E staining. For those of you who do laboratory medicine, we still use H&E staining. And indeed, this is an H&E stain of an adenocarcinoma. And it was this sort of thing that Virchow saw, and they actually drew pictures. No photographs in those days. Well, there were some photographs, but they certainly weren't through the microscope at that time. But they drew pictures of what is cancer and published them in journals and books defining profiles of cancer. And this is a cell going through mitosis, and this is prophase, metaphase, anaphase, and telophase. And I can see Dr. Vizzini sitting there thinking that I stayed up all night memorizing those. But this is what mitosis is, and cancer is uncontrolled mitosis, uncontrolled cell growth, 1 to 2 to 4 to 8 to 16 to 32, and so forth. Once these cells become uncontrollable in terms of cell growth, they can spread and interfere with bodily functions. This is a bone scan. This is, you can see the outline of this individual's rib cage and their pelvis and legs and so forth. All the dot spots except for this one are where the bones are lighting up, where there's osteoblastic activity because of metastases of cancer. The bone scan tells you literally that this person has spread of disease to many of the ribs, to the spinal cord, even to their legs up here. You can see some involvement in the shoulder. This, by the way, is where they injected the radioactive dye, and that's the bladder, which actually accumulates the radioactive dye. The blood is filtered by the kidney and goes down, but all these other dark spots is spread of cancer, and this is someone who has widely metastatic stage 4 adenocarcinoma. In this case, this was a person with prostate cancer, but this could be a breast cancer, this could be a lung cancer, any type of adenocarcinoma. Now, cancer, as a significant public health problem, I've already mentioned, it was relatively rare in the 18th and 19th centuries. Increasing rates of diagnosis, especially in the 20th century and throughout the 20th century, to parallel that death curve I showed you earlier. Today, cancer is a disease with a median age of diagnosis of 64. For those of you who don't do the sciences, that means half of all people who are diagnosed with cancer are diagnosed before the age of 64, and half of all people who are diagnosed with cancer are 64 or older. Now, lung cancer, let's talk specifically about lung cancer. Very rare in the 19th century. Increasing diagnosis rates throughout the 20th century. There was the questions, why is there an increase in lung cancer? And speculation early on was industrial pollution, street pavement products, chemicals used in World War I. Keep in mind, the car was very new in the early 20th century, and we converted from dirt roads to roads with blacktop, and there was actually a lot of early speculation that it was fumes from that blacktop that was actually causing the increase in lung cancer. The first mentioning of cigarettes causing lung cancer actually was from Fritz Lickert, who was a German epidemiologist in Dresden in 1929. Much of his work was not known to the Western world until well after World War II. Another German, Franz Müller, in Cologne in 1939, did a study of a group of people who had died of lung cancer and noted that they smoked. Some of you, if you've traveled and been to New Orleans, recognize the Ochsner Clinic. Alton Ochsner was the founder of the Ochsner Clinic eventually. Before he founded the Ochsner Clinic, he was a surgeon at Charity Hospital in New Orleans. And he worked with an LSU medical student named Michael DeBakey. People who are my age will recognize Michael DeBakey as one of the leaders in the field of cardiac surgery and doing cardiac transplant, vascular surgery, and especially bypass grafts. Michael DeBakey became an amazing force in medicine throughout the 1960s, 70s, and 80s. But in 1941, as a medical student, he and Ochsner did a series of studies on autopsied patients, and they're the first Americans to note that there were a large number of people who died from lung cancer who had a history of smoking cigarettes. Now, the first real big news about smoking and lung cancer came from later Sir Austin Bradford Hill and Sir Richard Dahl. I actually had the privilege of working for Sir Richard Dahl for a time. I'm that old. Dahl and Hill did a series of studies, first in 1950. They looked at 1,357 lung cancer patients, looked at them and matched them by age and gender to people who did not have lung cancer, and they said, gee, there's something about smoking. Ernst Winder and Everts Graham at Washington University in St. Louis looked at 605 males with lung cancer, compared them to age-matched controls, and came up with the exact same thing. Daniel Horn and E. Kyler Hammond. Kyler Hammond had my job at the American Cancer Society in the 1950s. There's about 5 people between the two of us. This is the paperwork. This is how you did an old prospective cohort study. Their cohort study, the Hammond and Horn study, looked at 205 white men, and they started gathering those men together in 1945, and in 1954 and 1958, they published what was actually still a surprising finding and actually did make the press at that time, and that is, gee, all the guys who died from lung cancer smoked cigarettes. Dahl and Hill at the same time looked at almost 41,000 British physicians and again found the same result. Interestingly, because there were no female physicians in the mid-1950s, we all of a sudden had data that smoking caused lung cancer in men. We did not have data that it caused lung cancer in women. Nevertheless, that led to this. This is Luther Terry's edifice. Luther Terry is the Surgeon General who in 1964 published the first Surgeon General's report on smoking in health. And this is the report that actually said that cigarettes cause both lung cancer as well as throat cancer and cardiac disease, which is another thing. Interestingly, cigarettes cause more cardiac deaths than they do cancer deaths. We now know that cigarette smoking causes at least 17 cancers, among them lung and head neck cancer with esophagus, bladder, stomach, pancreas, kidney, several leukemias, 17 different cancers, even causes, by the way, through secondhand smoke, crib death. But anyway, this is smoking in the United States. Again, pardon the graph. The thing to remember here is in 1955, 55% of adult men in the United States smoked cigarettes. and by 2010 it's about 20%. And actually there's now some data to show that it might be 16, 17%. In 1965, 35% of American women smoked cigarettes, and they're down around 15% today as well. Now, this is smoking as we know it today. It is still the leading cause of cancer. More on that in a little bit. But smoking is a problem that we can attack. You will note the states in the darkest red, starting with Arkansas and Mississippi, Tennessee, Kentucky, and West Virginia. Those are the places where we have the heaviest smoking. Nearly a third of adults smoke cigarettes in West Virginia. You'll see in several states, namely Utah and California, smoking rates are now between 10 and 13%. I guess I should put the caveat. In California, it's 10 to 13% who smoke tobacco, right? How we can further lower the smoking rate, looking at the economics of tobacco, which is a tax issue, looking at mental health issues, looking at agricultural issues. These are all important questions in cancer control today. Right now, we're very concerned about e-cigarettes. There's a tendency of young people to start smoking e-cigarettes and then convert to combustibles, but there's a tendency of young adults in their 20s and 30s who smoke combustibles to use e-cigarettes to wean off them. E-cigarettes are safer than combustibles, but they are not safe. So that's the big issue today. Now let's talk about cervical cancer. Tremendous history here. It was the most common cause of cancer death in women in the United States and Europe in the 1920s. It killed women aged 30 to 50. It had been linked to sexual activity. There was literally studies that showed that nuns never got it, prostitutes commonly did. It was thought to be a sexually transmitted disease, and there was for years the search for an agent. There was even data to show that if a man's wife died of cervical cancer, his next wife was more likely to get cervical cancer. Today, the death rates are dramatically lower, at least in Western countries. That is not true in Africa and some Asian countries. It is still the leading cause of death in many African countries among women, and it is currently the second leading cause of death in women worldwide. Huge disparity between Western Europe and the United States and the rest of the world. Now, this is George Papanicolaou. He invented this thing which we call the Papanicolaou smear, but nobody can say Papanicolaou, so we call it the Pap Smear. This is a Pap Smear. It is brushed off exfoliated cells from the cervix, again on a glass slide, stained and looked at through a microscope. And there are ways in which we can say these cells are on their way to becoming cancer, or these cells are cancerous, or these cells are normal. This is Harold Zerhausen, 1985 Nobel Prize winner. Dr. Zerhausen is the guy who figured out that the infectious disease that causes cervical cancer is the human papillomavirus. You know, from 1930s onward, we were looking for the sexually transmitted disease, and Zerhausen found it. It's not just all HPVs, it's primarily HPV type 16 and 18. There are about 50 some odd types of HPV, by the way. Several other types, and we'll show you a list of them in a minute, cause cervical cancer as well, but it's 80% caused by HPV type 16 and type 18. Other types of HPV cause warts. It is a DNA virus, and DNA viruses are vaccinable. So, the development of the HPV vaccine set off in the 1980s, and as many of you know, we actually finally developed a vaccine. It was tested primarily in South Africa, found to be very safe and effective, prevents dysplasia, and we use dysplasia as a surrogate for preventing cervical cancer. Interestingly, we've never proven that the cervical cancer vaccine prevents cervical cancer. It prevents dysplasia. which is on the road to cervical cancer. So we assume it prevents cervical cancer. Initial vaccines were for type 16 and 18, and then they added 2 additional types. And today we have a 9-valent vaccine, which has all of these vaccines as well as these, and it prevents some cervical warts as well as some cervical cancers. Again, it is safe, effective. There's been significant uptake in Africa and Asian countries, but about 1/3 of women in the United States have gotten it to this point. We're recommending that girls aged 9 to 12 get it, get 2 shots now, and girls who are older than that who have not gotten the vaccine get 3. It was initially promoted for women, but we're also now suggesting that men get it. Some say, why give men a cervical cancer vaccine? There's actually a couple of reasons. Number one, if we're interested only in cervical cancer, and if I were czar of the world, I would only vaccinate men, because no woman has ever given another woman HPV. Okay? So more emphasis on vaccinating boys. Now, today, I should point out HPV has been found to be linked not just to cervix cancer, but to vulvar cancer, vaginal cancer, penile cancer, anus cancer, and cancer of the head and neck, specifically the oral pharynx. The oral pharynx, when you say ah, what the doctor's looking at in the back of your throat, that's the oral pharynx, and then the tonsils. Most people know where their tonsils are. But these are the organs that HPV causes cancer, and we have pretty good data to project that the HPV vaccine can actually decrease the number of cervical cancers by 80%, and many of these other cancers by 90% or more. So there is a benefit to the boys, by the way, in getting HPV. We actually find right now there is an epidemic of white men aged 50 to 65 with head and neck cancer that's caused by HPV. Very brief history of breast cancer. This is William Stewart Halstead. He was the chair of surgery at Johns Hopkins, and in 1895, he defined for us the Halstead mastectomy, which involved removal of the entire breast all the way to the point that in the OR, the doctor could actually count ribs, and then going all the way up to the third level of lymph nodes in the armpit and removing them. If a woman got the Halstead mastectomy and got it done appropriately, by definition, she had lymphedema. Her right arm, if it was the right breast, her right arm would be swollen for the rest of her life, and she would not be able to raise her higher than this for the rest of her life. That was the Halstead mastectomy as defined in 1895. One of the mistakes in medicine is we continued doing that operation well into the 1980s. And it was these 2 gentlemen in the late 60s, Bernie Fisher at the University of Pittsburgh and Umberto Veronese at the European Institute of Oncology. And in my Forrest Gump life, I've had the privilege of knowing both of these gentlemen. They actually started a series of studies in the 1960s that actually first looked at removal of the breast only, the simple mastectomy. And they actually proved that removal of the breast only was equivalent to this operation that we had been doing for 75 years where women couldn't raise their arm. And they showed that this removal of the breast only, a lot less morbid, just as effective. And so you would think medicine would start moving toward the simple mastectomy. Some doctors were just very set in their ways and would not change. These guys pressed it even further. They actually then did a series of studies to show that you could just whittle out the tumor. That's not a surgical term, by the way. You could just remove the tumor and radiate the area where the tumor came from, as opposed to doing the simple mastectomy. And so in a series of about 15 years, by 1980, they showed us that instead of doing this Halstead mastectomy, which was incredibly morbid, a woman with breast cancer could actually keep her breast. So we went from the simple mastectomy to lumpectomy and radiation. In the late 1980s, Fisher and Veronese and several others actually started showing us that we could even improve survival rates by giving women who had had surgery and no evidence of disease additional chemotherapy, because a certain proportion of those women actually had disease that was in their body and we couldn't find it. Yes, they have no evidence of disease, but there's disease there we can't find. We give the chemotherapy and we kill off that disease we can't find, and the end result is they don't relapse. This is a mammogram. Mammogram is an x-ray of the breast. This is a mammogram on a person who's probably in their 60s, and you can tell how old someone because the mammogram of a woman who is 20 years old is white. The breast is white. The mammogram of a woman who's 70 years old, the breast is black. The tumor is always white, so if I'm looking for a cancer in a woman who's in her 20s or 30s, I'm looking for something that's white on a field of white. And actually, because breast cancer is relatively rare among people in their 30s, I'm looking for something that's not likely to be there on a field of white. All right? Because breast cancer is very common among women in their 60s and 70s, I'm looking for something that's more likely to be there that is white on a field of black. And that's actually part of this issue when you hear about should we start screening at 40 or 45 or 50. But this is a mammogram, and we're pointing at this white thing which needs to be biopsied, because that is a cancer. Now, Sam Shapiro, who is a professor at Hopkins, did the first randomized trial of mammography. He took a group of women and he randomized half to get screened and half not to get screened and followed them throughout the 1960s. And by the early 1970s, he noted there was about a 20% decrease in risk of death. Today, we have 10 clinical trials that suggest that mammography decreases risk of death by about 20%. Some show it to be as high as 35%. Mammography is now recommended for normal risk women. And we have this question, should we start at 40, 45, or 50? The question is not, do women in their early 40s need mammography? Because women in their early 40s do die from mammography. The problem is, it's so hard to interpret a mammogram among women at this age. And part of our message, and this is something that I personally have not done well enough, is we need to communicate that we need a better test. It's not, should we screen women at 40 or 50? It's, we need a better test. Certainly for women in their 40s, but we need a better test for women in their 50s. I told you it decreases relative risk of death by 20%. That means 80% of the women who are going to die are still going to die. We need a better test. Quality of the image and quality of the radiologist is also an incredibly important thing. Now, in breast cancer in the United States, I showed you that huge drop of 25% from all cancers. Breast cancer in the United States, we whittle along with 30 to 33 women out of every 100,000 die from breast cancer every year throughout the 1970s into the mid-1980s. And all of a sudden, the rate starts going down. And we've actually had a 35% drop in breast cancer deaths in the United States since the late 1980s. That's a really good thing. A woman's risk of dying from breast cancer today is 2/3 what it was in 1987. That's a good thing. We need to do better. These are the states in the United States that have not had a 10% drop in breast cancer death rate over the last 30 years. I could actually get the drop in the United States up over 45%. I could actually have a woman's risk of death from breast cancer in the United States if we threw these states out of the United States. This is a huge problem. Is the biology of a woman in Louisiana or Mississippi different from the biology of a woman in Massachusetts? The actual answer is people in these states don't get as good a care, both preventative services and medical services, as people in the other states. There are disparities in quality of screening, quality of treatment, and there's just the fact that some Americans do not get adequate health care. Let's look at colorectal cancer. We got good studies to show that stool blood testing, 3 samples, I'm sorry, I'm talking about stool right after lunch. Sigmoidoscopy every 3 to 5 years, colonoscopy every 10 years, all those things work. By the way, the data that show that stool blood testing saves lives is actually stronger than the data that show that colonoscopy saves lives. In this country, we love to do colonoscopy because it's fiber optic and high tech and, stool on a card with some chemical. Ugh. Okay, but in any event, all those tests work. Now, this is a little convoluted. I'm sorry to show you this one. 0.8 is 80%, 0.9 is 90%, 0.7 is 70%. This is actually a little Apple to PC problem here, but this is actually 5-year survival, 60 months out here at the end, okay? This is red is people who are insured. The dotted lines are people who are uninsured. Red is stage 1, blue is stage 2. This is the 5-year survival of people who are uninsured with stage 2 colon cancer, the 5-year survival of people who are insured with stage 2 colon cancer. This is the 5-year survival of people who are insured with stage 1, and the 5-year survival of people who are uninsured with stage 1. And this is just to show you that in the United States of America, a person is more likely to live for 5 years after the diagnosis of early stage colon cancer if they have insurance versus if they don't have insurance. And a person is better off having stage 2 colon cancer with insurance than stage 1 early colon cancer without insurance. This is simply to show that insurance matters, and whether or not someone has insurance determines whether or not they're going to live or die with cancer. Now, this is colon cancer, the drop in mortality in Massachusetts and New York State over the period 1990 onward, and this is the drop or lack thereof in Mississippi and Alabama over the same time period. I'm talking about disparities in outcome, and I'm talking about disparities in a non-traditional way. I could talk about black, white, or rich, poor, but I'm talking about Massachusetts versus Mississippi. People are dying because they're not getting adequate care. Quality of screening, quality of treatment, all these adequate care things are issues. And if we want to save that 150,000 lives a year, we need to work on getting people adequate care. Now let's talk a little about the causes of cancer, because there's some disparity issues there as well. Let's start at the bottom. 33% of all cancers are due to tobacco use. What's frequently not appreciated is 30%, the biggest risk factor is obesity, poor nutrition, and physical inactivity. Now this is where the fat guy talks to you about obesity, okay? It is the number 2 cause of cancer in the United States. It's been linked to 12 different cancers. Not just obesity, by the way. It's too many calories and not enough physical activity. Think of it as a 3-legged stool. Everybody wants to blame obesity, and it's too many calories and not enough physical activity. And you can see the other things that cause cancer. Viruses cause about 5% of the cancers in the United States. Genetics. We won't talk about alcohol. UV radiation, that was a joke, folks. UV radiation, like from the sun. Okay, obesity, lack of physical activity, and poor diet is going to surpass tobacco as the leading cause of cancer within the next 2 decades, if it hasn't already. Smoking rates are going down. Smoking as a cause of cancer is going down, but obesity, too many calories and not enough exercise is going up. It is going to cause a tsunami of chronic disease, diabetes, cardiovascular disease, orthopedic disease, as well as cancer. Orthopedic disease, hip and knee replacements because of arthritis. Okay? This is obesity in the United States going from 1970 onward. You can see 15% of American adults were obese, or less than 15%, more like 13% were obese in the early 1970s, and it has risen. It's over 35% today. These are a few of my other favorite countries to look at for obesity. England is number 2, but they're not nearly as obese as in the United States. You can see Canada, Spain, France, Switzerland, Italy, Korea. Indeed, if you were to look at obesity by race and ethnicity, today, well over 50% of Black American women are obese. If you put obese as well as overweight together, it's well over 80% of Black women are obese or overweight. For Hispanic women, it's slightly less than that. There are huge issues with obesity, too many calories, and not enough exercise. One of the things that we as cancer control experts are looking at is what's called the built environment. One of the reasons for this problem is, and I'm talking to a young audience here, but the older folks can actually appreciate this. In the 1950s, every American family wanted a car. By the 1980s, every American family had 2 cars. In the 1950s, we would walk to a grocery store every other day or every 3rd day to buy some fresh fruits and fresh vegetables, and then we would carry them home to our house to cook them and eat them. By the 1980s, and by the way, we would store them in these things we called an ice box in the 1950s. By the 1980s and 1990s, we had these beautiful refrigerator freezers, and we would drive our cars on Saturday morning to the grocery store because we'd moved to suburbs that didn't even have sidewalks. And we would fill up the trunk of our car with these processed foods. No fruits and vegetables for me. I'm going to use processed foods. And I'm going to bring them home, and I'm actually going to cook them in the microwave. All right? And if I didn't use those processed foods in the microwave, I'd go to this fast food restaurant with the big M. By the way, when Tony and I were born, there were 6 of those in the United States. Now I think they're opening 6 a day around the world or something outrageous. And by the way, Wendy's gave us the drive-through in 1982, so we don't get the exercise of getting out of the car to walk to get our extra calories. All right? Our way of living has changed dramatically. By the way, foods have become higher in carbohydrates, and calories in the United States, cheap calories in the United States are a huge problem. And this is all contributing to part of the cancer problem. Now, finish up the talk. This, I'm sorry, it's kind of dark. That's Richard Nixon. For you young people, Richard Nixon was the President of the United States. All right. And this is December 23, 1971. He is signing the National Cancer Act. Ted Kennedy referred to this as Richard Nixon declaring war on cancer. Richard Nixon never called it declaring war on cancer, but Ted Kennedy did. And out of that came a lot of things. A lot of money went into research. And You know, I was talking to somebody this morning about genomic testing and genotyping. That all came out of the research that came out of the National Cancer Act. It just fueled money into the National Institutes of Health and the National Cancer Institute for a huge anti-cancer effort that gave us just an amazing amount of knowledge. Indeed, we're starting to actually even understand cancer in ways such that I frequently talk about how we're moving to a 21st century definition of cancer from that mid-19th century definition that Virchow gave us. We really do now have a totally different definition of cancer, and we're moving into the era of targeted precision medicine where we're tailoring therapy. We're moving into an era of immunotherapy where we're actually able to make someone's immune system look at their cancer as being foreign and attack their cancer. It's actually an amazing time. This is another biopsy. This is H&E staining of lung cancer with signet ring features. You needn't worry about why it's a lung cancer, just take it. This is what we would, over the last 150 years, use to say this person has adenocarcinoma. This is lung cancer, classic lung cancer. From 20% of the people who get this are non-smokers, 80% are smokers, but this is classic lung cancer. Today, I as a clinician don't stop at the patient has lung cancer. I want to know what's going on genetically, because 2% of lung cancers have a BRAF mutation. I have a drug called sorafenib, which is pretty good at attacking BRAF mutated lung cancer. Doesn't work a squat for the other 98%, but if a person has a BRAF mutation, if they're one of that 2% with a BRAF mutation, I have a drug that's really good for them. ALK mutations, it's about 8% have ALK mutations. And I have a drug, it's called crizotinib. I just like saying crizotinib. I'm the only person I know who can say crizotinib. But anyway, crizotinib is a great drug for people who have ALK mutations. And by the way, an ALK mutation is actually it's actually a lymphoma kinase. The A stands for acute, and the L stands for lymphoma, and the K stands for kinase. I just use that as a lesson. You know, as the chief medical officer of the ACS, I have all these people who come up to me, and they literally will say, "Screw prostate cancer." Screw prostate cancer. Where? Oh, is there an electric fence? I thought somebody didn't like the word screw. Okay. All right. Literally, people will come to me and say, screw prostate cancer research, put all the money in breast cancer research. Well, the ALK mutation was discovered doing lymphoma and leukemia research. Crizotinib was discovered doing thyroid cancer research, and they were married together by people who didn't just do lung cancer research, but people who kept a broad, open eye to the literature. And if we had said, screw all other cancer and just do lung cancer research, we would have never gotten crizotinib for lung cancer research. And that's my plea, that we as researchers need to keep a broad, open mind, not focus too much on one disease, and I as a research administrator need to fund the lowest hanging fruit. I need to fund the research questions that are most easily answerable and then try to apply them further than that. Now, other types of lung cancer, EGFR mutated lung cancers, KRAS mutated lung cancers, we're developing drugs for all of those things. And so, hopefully over the last 45 minutes or so, I've shown you that we've made some progress, but we could have made greater progress, and we can still make progress. There's been incomplete application of much of what has been learned in cancer control. If I can leave you with one question, the thing that we need to focus on the most is how can we provide adequate, high-quality care to include preventative services to populations, however we define them, that so often don't receive them. Because one of the things that, and I'm going back to Washington tomorrow night, one of the things I don't hear in Washington is how do we provide adequate care to human beings who deserve adequate care. Thank you. You guys ever see those electric fences they have for dogs? I think, anyway, do you have any questions for me? Yes, ma'am. Yeah, there are some dairy products that come from cows that have been stimulated endocrinologically in various ways. Some of those stimulants are growth hormones. The growth hormones actually don't end up in the actual product that we eat. And so I don't, and even if you were to eat a growth hormone, it would be digested in your stomach and it would not actually cause growth in the person consuming it. So I actually think that some folks there are barking up the wrong tree. I do worry sometimes about things like eating too much soy, especially breast cancer patients, because soy has certain estrogens in it. And estrogens do fuel breast cancer. I'm not a big believer in a lot of these grocery stores that have organic products and that sort of thing. I'm a big believer in rinsing off the fresh fruits and vegetables before you eat them. But sometimes I think that these focusing on these things too much. I've actually seen some harm done with some of these things. You know, we once noted that people who have low selenium levels have a higher risk of certain cancers, and we thought, gee, what we should do is give people selenium. Then we said, gee, people who have low vitamin E levels have higher risk of certain cancers, so we should give people vitamin E. Then we said, gee, people who have low levels of beta carotene have higher risk of cancers, so we should give people beta carotene. I don't know why we didn't think about just giving them fresh fruits and vegetables that have selenium, vitamin E, and beta carotene. By the way, high doses of selenium from the CVS or Walgreens. You have CVS here? Yeah. High doses of selenium from the CVS in clinical trials has been shown to increase risk of diabetes. High risk of vitamin E from the CVS has been shown to increase risk of stroke, and high risk of beta carotene in smokers has been shown to increase their risk of lung cancer beyond the risk that they had from smoking alone. I've yet to see anybody say that cantaloupes increase risk of. Seriously, we've actually started saying we need to be giving these things through foods rather than through these nutraceuticals. Anything else?
I have a question.
Yes.
Are you seeing any results in decrease breast cancer or increase in diagnosis from the 3D mammography?
Oh.
Or colorectal cancer?
I hope you don't own. Okay. Yeah, I hope you don't own stock in those things. 3D mammography, actually, the book that I wrote was all about how we waste a lot of money in the United States on healthcare and don't get much out of it. And 3D mammography is a classic example of that. For those of you who don't have to do it, if you get a mammogram every 1 to 2 years, the Mammography Center is now asking women if you will pay extra above what your insurance will pay for the 2-dimensional mammogram to get a 3-dimensional mammogram. And they make it sound like the 3-dimensional mammogram is better than the 2-dimensional mammogram. In the clinical trials that got the 3-dimensional mammogram approved by the Food and Drug Administration, they were able to show that a 3-dimensional mammogram, which provides more radiation to the breast per image, makes a poor mammographer into a better mammographer, but does not improve the average mammographer. Okay? So I'm not a big fan of 3D because one of the issues that's rarely talked about is if you do mammography every year from age 40 to 74 and you do it for 100,000 women, we already have the calculation that we're going to cause 130 breast cancers, 16 of which will kill women. Mammography actually kills. Now at the same time, if you do that mammography on 100,000 women, you're going to save the lives of somewhere between 800 and 900 women, but you're going to hurt 16. All right. Now, if I actually decrease the number of mammograms in that 100,000 women from age 70 to 74, 75 to every other year, I decrease the amount of radiation, therefore I decrease the number of breast cancers that I cause, and I also decrease the efficacy or number of lives saved, but not by much. And so I'm constantly trying to balance the benefits and harms there, and 3D mammography actually just offsets that balance when I know that one intervention is just get a good mammographer. Colacard. Colacard is a test. We're going to really talk about stool now. Colacard involves sending off money to this zip code in Madison, Wisconsin. It's a zip code you never want to visit. And they send you this bucket. And you deposit something in this bucket. And then you mail this bucket back to that zip code. There's a post office in Madison, Wisconsin. Okay. Now, at the Colacard lab, they open this bucket and they, I kid you not, liquefy the stool. And then they do PCR, polymerase chain reaction, on the stool looking for certain RAS gene sequences that are commonly found in colon cancer. And if these RAS gene sequences are found, it means the person likely has either a polyp or a colon cancer. The polyp can be benign. And then the person needs to get a colonoscopy. If the thing is negative, it means that the person is probably okay. Now, Colacard cost about $500 to do. Now, stool blood testing 3 times a year, which costs $10 per test, $30 total dollars, is actually scientifically been proven to be more effective than Colacard. But some people just have to have high tech. Yes, sir.
I am from computer engineering area.
Mm-hmm.
And there are many other engineers from different fields. They are trying to contribute to cancer research. As an academician, what kind of opportunities we may have to collaborate with you?
Yeah. Well, the question is, what can engineering contribute in terms of collaboration in cancer control? One thing is, we talked about how the 3D mammography makes a below average radiologist an average radiologist for reading the mammogram. We may be able to take the two-dimensional digital mammogram. X-rays are digital just like your camera pictures now. We may be able to take those digital two-dimensional images, put them through a computer, and have a computer read it. So I don't need to find an average or above average mammographer to read my mammogram. I need to find you and your computer. That's where the future is. And that way that patient doesn't get that radiation, that extra radiation from the 3D mammogram. I'm actually very hot on the use of computers to actually process images. One of the things, we talked about this last night at dinner, I showed you those biopsies of lung cancer and breast cancer. There are certain biopsies where it is a close call in the pathologist's eye. And if you find a pathologist who's actually truthful, he or she will actually say, it could be cancer, but I don't know. All right? There is room for computer analysis of the image to actually come up with an objective call for, is it cancer? I am very hopeful that with supercomputers we can actually collect the collective treatment experience of thousands, hundreds of thousands of people with cancer, and actually start figuring out that one thing that we did works better than another, or one thing doesn't work. Because I do a lot of these 500-person randomized trials that last 10 years, while there's a lot of people just getting standard treatments out there, and we could assess those standard treatments with the computers. So I actually think computer technology, and especially machine learning and the large supercomputers, are going to help us in medicine an awful lot. We're struggling with that right now, but I think the future is very positive for people like you in medicine. Yes, ma'am.
What's your opinion on preventative screening for prostate cancer?
Preventative screening for prostate cancer. Are you a plant? All right. PSA screening is, I'm actually writing a book on that right now. PSA screening came to us in the late 1980s, and it was a blood test. And it was very clear that it found prostate cancer, but it was not actually clear that the men who were diagnosed and treated benefited from that finding. And it actually took off like wildfire in the United States, partly because there was a lot of money made off of prostate cancer screening and treatment. We still don't know if PSA screening saves lives. There are some clinical studies to say it does. There's actually one clinical study to say that it does, and there are several clinical studies to say that it does not. All of those clinical studies show that it diagnoses a lot of disease, but does it lead to saving of lives? All of those studies are flawed, including the study that says it does save lives. Now, if you want to apply the study that says it saves lives, I'm going to give you the argument for prostate cancer screening, okay? The current argument for prostate cancer screening is that for every 200 men who you diagnose with localized prostate cancer through screening, and you treat with radical prostatectomy, at 15 years after diagnosis and treatment, you will have prevented 8 of the 200 from dying. At the same time, 16 of the 200 will have still died, and early on, you killed 1 out of the 200 by treating them. They died as a result of complications of treatment. You have done nothing for the other 175 except tell them over the last 15 years that they are a prostate cancer patient and give them all the side effects of treatment. Now, the side effects of radical prostatectomy, in the majority of the men who were able to have sex will be rendered impotent. The majority of the men who did not have urinary incontinence will have urinary incontinence, and many of them will have diapers. So the argument is you have not done the 175 a favor. You have not done the 16 who still died a favor. You sure as hell didn't do the one guy who died from surgery a favor, but there's 8 guys who are pretty happy. That's the argument for prostate cancer screening given today's science. But I can make a lot of money doing it. Unfortunately, that the last statement I said sort of funny, but that's a really sad statement. I literally, in 1998, I was one of the people who negotiated the President Clinton's apology at Tuskegee. And I went to the White House and I saw Bill Clinton cry as he apologized for a clinical trial where we lied to a group of 600 black men for about 40 years. And literally lied to them and deceived them and actually killed some of them. 2 weeks later, I go to this major American medical center. This is a place that all of you guys have heard of. And I'm the big guy from the federal government, and we fund a lot of research there. And so they have to put on the dog and pony show to explain to me how they are so great. And I'm sitting there, I'm listening to some pretty good science, and then I started hearing their marketing guy is sitting next to me talking to me, really an annoying guy. And I want to hear their science, but he's explaining, he's really proud of their business plan for prostate cancer screening. And he explains to me, this is 1998, he explains to me if we announce 8 weeks ahead of time that we're going to do free prostate cancer screening at the mall, this is how much free press we get. We're going to get announcements on NPR, we're going to get all this other press coverage, and from that, this is the bump in business we're going to get in our mammography clinic. This is the bump in business we're going to get in our chest pain clinic. This is wonderful. Yeah, they get a bump in their mammography clinic from women who are not going to go get prostate cancer screening. When they get to the clinic, or when they get to the mall that weekend, for every 1,000 men, and he explained this, for every 1,000 men over 50 who raise their sleeve and say, please screen me, we're going to have 155 men who test positive. And we're going to charge that 155 men $3,000 per man to find out why they are positive. And then he reminds me, uninsured men don't volunteer for free screening. Of the 155 men who have a positive, they're going to hit bingo on 45. That was his term, bingo. Of the 45, he knows how many are going to get radical prostatectomy, for which they're going to charge their insurance about $30,000. He knows how many they're going to get external beam radiation, for which they're going to charge their insurance about $80,000. Then he starts explaining to me of the 45 men that they treat, he knows the number of men who are going to have urinary incontinence so badly that diapers just don't do it for them. He, in his business plan, if we screen 1,000 men, this is how many artificial sphincters we're going to sell, and our urologists are going to insert in these guys to keep from wetting themselves. And then he's apologetic. You see, this new thing called Viagra just came out last year, and that screws up his experience on how many men are going to be so upset about their impotence that he doesn't know how many of these penile implants that you pump up, I don't want to get X-rated, that they are going to sell to guys who are upset that they can't get an erection. Viagra just screwed that estimate up. But you know, I'm a smart guy. I went to the University of Chicago, okay? I'm smart. I said, if you screen 1,000 guys, how many lives are you going to save? And that guy put his hand on my shoulder and he said, Dr. Brawley, don't you know there's never been a study to show that prostate cancer screening saves lives? The study I just quoted for you was published in 2009. This conversation was 1998. He said, there's never been a study to show that prostate cancer screening saves lives. This is all about making money. Okay? That's part of the problem in American medicine. Now, you guys want to go into American medicine, you guys need to fix that. I encourage you to go into medicine and not be turned off by it, but you need to fix that. We need to be a society that's much more concerned about how are we going to get good care to people who need it, as opposed to get extraneous care that makes money for us to people who don't need it. By the way, there's an estimate that the prostate cancer screening and treatment frenzy in the 1990s. Screening was so popular, Bob Dole had it done on the floor of the Republican convention in 1996. I mean, it was popular. And there's now an estimate that we diagnosed and unnecessarily treated more than 1.5 million American men with prostate cancer screening. Long-winded answer. Any questions? I turned everybody off now, huh? Thank you very much. No problem. Pleasure.
Everybody, please join me in thanking Dr. Brawley again. This was enlightening for me. Okay, so I know there's some, where are the PA students at? I know you've got a guest speaker, right? And so we're officially done. So thank you for coming over from Old Town, and thank you everybody for coming. Thank you so much.
No problem. No problem.